Muchas gracias por invitarme. Yo no puedo hablar español tan bueno como antes, presentador antes, pero en fin, si quieren preguntas, a la orden. ¿Sí? Ok. In the 1951 classic, The Christmas Carol, the ghosts of past, present, and the future, they convinced Scrooge to share his wealth with the poor people. The history of interoperability hasn't quite been such a great story. There's a lot of data Scrooges, if you will, and convincing them to share data has been a really difficult challenge. Their actions have forced the US government to legally mandate sharing through interoperability. They had to create laws to create the companies and different hospitals to share data. But the story isn't over yet. So I've spent the last 20 years or so either in IT, health IT, data science, or in healthcare. And I just really appreciate the opportunity to talk today. I'm going to give a high-level overview of interoperability, the past, present, and future, and then just think where it could go in the near future. So Sema Verman, she's the current administrator of the Centers of Medicare and Medicaid, and she stated one of her missions as head of CMS is to break down barriers to interoperability. Last year she complained that healthcare remains in a 1990s time warp and wanted for an end to all physician fax machines. Now that sound, if it was louder, it may have been a little bit strong and shock you a little bit. Painful, maybe. It was very painful as a medical student, as a resident, doing scut work, as we call it, basically sending faxes, receiving faxes, doing all the different jobs that the attendings didn't want to do. Often faxes would get misplaced, they would get thrown in the trash, they wouldn't be sent. It was kind of a game, but it really wasn't very fun. When one thinks of the US healthcare system, you may think of a very seamless, highly technical system, but the sad truth is that a lot of fax machines are still used in the clinics. The sound on the previous slide was the 1990s calling, saying, "I want my fax machine back." Faxing technology was developed about 200 years ago. About 20 years before the light bulb was invented. And in 1966, Xerox created the T30 protocol. And these are essentially the same protocols that we use today sending faxes. So there's no need to explain the importance of standards to this crowd. There are probably some concerns with using a two-year-old, or almost a two-century-year-old technology and almost a 40-year-old protocol to transfer data. So here's some stats on the faxing in the US healthcare system. It gives you an incomplete picture of the patient. It can lead to greater costs, greater chance of medical mistakes, and actually ends up with greater resource utilization. There are some hefty financial penalties for sending to the wrong number. You can see $2.5 million. And finally, in DEF CON, last year, a group found that there was a way to actually send, a way to overtake a whole network using a fax machine. They called it Faxploit, and they actually released the code. And this is, skip the slide, sorry. So in July of 2018, the UK released the fact that 9,000 faxes are being sent between their hospitals. And similar to CMS, as I mentioned earlier, the British Department of Health argued that more modern communication methods are needed. So 6 months later, the NHS, National Healthcare System of the UK, actually said that by April 2020, we're outlawing all faxes. So although faxing may not be ideal, it's been the mainstay, really, of interoperability in the United States for many years. So fortunately, the US government, Cerner, and many others have been on a mission to improve interoperability. And there's a tremendous movement behind improving interoperability. This cartoon illustrates the benefits of interoperability for doctors and clinicians. So the value of having real-time information really can't be overstated. The provider and patient experiences are completely different with and without interoperability. So Cerner's vision for interoperability can be summed up as giving providers the necessary data, where they want it, when they want it, and how they want it. So achieving a vision like this requires HIT leaders to think differently and go beyond old technologies like fax. So in addition, more recently, there's an issue with what we call physician burnout. And it's thought that physician burnout will be helped by having access to data, preventing them from having to enter data again, and getting everything they need at once. And hopefully we can overcome this crisis with interoperability. So Cerner may have this vision, but is there actually any evidence to back up interoperability is useful? So the simple answer is yes. So a brief review of the literature yields that many peer-reviewed studies exist on interoperability and the benefits. So I was able to find, for example, 4 studies that showed a reduced in healthcare cost, fewer readmissions, fewer orders, fewer tests, and procedures. 2 studies showed an improved care quality through better medication reconciliation. And 3 papers provided evidence for superior population health, such as higher immunization rates, identification of patients that could benefit from interventions. So as we're nearing the holidays, it's getting close. People are putting up decorations for Christmas in the US a little early. So I'd say the wish list, if you will, for the US healthcare system, that what we hope to achieve in our interoperability is this. We haven't really eliminated faxing yet, but we have made progress on these goals. And I'd like to summarize for you how we got to our current state, interoperability, essentially where it is now and then where it could go. So the idea for healthcare interoperability is not new. It started with the Health Insurance Portability and Accountability Act in 1996, which we affectionately call HIPAA. The primary goal of the law was to make it easier to keep your health insurance, to protect the confidentiality and security of healthcare information, and to keep down administrative costs. It also mandated the creation of a universal patient identifier, or I'll call it UPI. From a data perspective, there's obviously a big advantage to having one single identifier for a person. It's superior to matching on things like name, date of birth, but can get really messy. Before a UPI could be implemented, a lot of people threw up their arms and complained. So in 1998, or sorry, not that much longer, in 1999, they actually prohibited the use of a UPI, and they said, you need to use patient matching instead because we're concerned about the security and privacy of individuals in the healthcare system. As you can see from the timeline on this slide, since that time, the U.S. has been actively advocating for interoperability since the introduction of HIPAA in 1996. The decade of health IT was announced in 2004 with the creation of the Office of the National Coordinator for Healthcare IT, or ONC. So, per the guidance of Congress, one of the main responsibilities of the ONC was to ensure basically less effortless patient matching and supporting the industry to get that done well, all without having any UPI. So despite the U.S.'s best efforts at interoperability, it was found that many were not exchanging data as we'd hoped. They were rather blocking information. It could be for good reason, but sometimes they found alternative reasons why they were not sharing data. And I'll quote from the Act, allegations continue to surface that some healthcare providers and health IT developers are interfering with the exchange or use of electronic health information in ways that undermine healthcare reform. So current economic incentives and characteristics of both healthcare and health IT markets create business incentives for some market participants to pursue and exercise control over data and not share. So in December, in response to that, in December 2016, the 21st Century Cures Act was pushed forth by President then Barack Obama. And it was designed to promote nationwide interoperability. The ONC was charged with implementing the provisions of this act. The act stated that connectivity between systems and networks remains an issue. Networks are fragmented, organizations hold on to data, they're not sharing, and there are variations in interoperability across systems. And the act strictly forbids any information blocking. One of the first sections, there are several sections of the act, but the first section was directed at the development of a trusted exchange framework. It was also called TEFCA. It provides a single on-ramp for you to connect to the interoperability network in the United States, and allows for secure transfer of information, and it supports nationwide scalability so it can grow. Section 4004 mandated that health information technology should not be developed in any non-standard way. It should not be developed in a way that increases the complexity or burden of those exchanging data. It should not lead to fraud, waste, or abuse. And it should not impede innovations. And if you break any of these rules, you will potentially even get a $1 million fine if you're caught. Even a developer could be at risk of that. So now that I've showed you some of the history of healthcare interoperability, with this slide I begin to discuss some of the present. Here I'd like to introduce to you the Commonwealth Health Alliance. It was co-founded by Cerner in 2013, and it describes itself as an independent, non-for-profit trade association. And it's open to all suppliers, health IT suppliers, and its simple notion it's devoted to is that health data should be accessible to individuals and providers no matter where the care occurs. The access to this data must be built into the different software programs, and it should be at a reasonable cost. And it could be used by a broad range of providers to serve the patients the best way. And Commonwealth is the main entry point for Cerner clients to enter into the interoperability system. They also use health information exchanges, as you can see in the diagram. And effectively, Commonwealth satisfies the two sections I showed you before. So with Commonwealth, sections 4003 and 4004 are satisfied from that act. So in today's world, as everyone is on their phone, as was talked about in the previous talk, that we have access to instantaneous information, right? It's in section 4006, the Cures Act argued that there's no reason why this shouldn't happen for patient information as well. So with that, and you saw a good introduction in the previous talk of the FHIR, the Fast Healthcare Interoperability Resources, and essentially developed out of the 21st Century Cures Act. So on the right side of this diagram, you can see some examples of consumer, we call them consumer apps, or apps for people that want to look at their health data. And essentially FHIR is, like I said earlier, one of the fruits of the seeds that was planted by 21st Century Cures Act almost 4 years ago. So this is a quick diagram of Cerner's history with interoperability. You don't need to look at all the details. It's a little bit messy and really involved. But since using HL7 standards in 1991, co-founding Commonwealth in 2013, and embracing the FHIR standard, Cerner, for their part, has been essentially a leader in interoperability. Interoperability has been a central tenet of Cerner's mission and designs in their systems. So other notable milestones I'd like to highlight is in 2007, clients used to create Shared Health, which was a Medicaid-driven health information exchange. In 2009, Cerner helped develop an interoperability certification platform. In 2014, Cerner demonstrated the use of a FHIR app with Boston Children's Hospital, which is a leader in pediatric care. And this year, Cerner saw the Commonwealth Care Quality Network go to general availability and become live, which I'll talk about care quality later, but it's essentially it's the other large network of interoperability in the United States. It was developed by Epic. So the last section of the 21st Century Cures Act I'd like to talk about is Section 4007, which mandated this patient matching that we still have to deal with because no one wanted a universal patient identifier, or UPI. So because we needed a universal patient, we did not have a universal patient identifier, organizations like Commonwealth are needed to ensure that there's interchange between systems, that patient at hospital A is the same patient at hospital B, making sure it's the same person and the records are the same. Commonwealth also serves as a record locator, a data broker, and they provide like a trust exchange framework that allows for everyone to be authenticated. But Commonwealth itself, just to be clear, they do not store any patient data. They just act as a broker. So here's a summarized list of the services that Commonwealth provides. Queries and responses of data, they're brokered. Individuals are enrolled in the network, and then their records are found. You can see that data comes from many forums, many venues, and I just want to reiterate that Commonwealth doesn't store any data, they just act as a broker. So as of March 2019, over 80 members participate in the Commonwealth Alliance. Some participate directly by contributing data, and others essentially just query and retrieve data. This is just a small list of what I could fit on the slide, or what could be fit on the slide. So this is a map of the United States, the continental United States, provider sites that retrieve or contribute information using Commonwealth. As of July of this year, about 1 million unique people were being added each month, while there's around 2,000 documents that are retrieved each week by Commonwealth. So these numbers are growing more and more as each time a new provider goes live or they deploy a new system, some new vendor. So I'd like to demonstrate what we call the interoperability ticker, which shows current transactions that are going on live. And I just want to show you, let's see if I still, I'll just, sorry about that. So these are actually live connections that are, as we speak, of data that's being sent back and forth across the United States, and you can see where it's coming from, where it's going. And these, in particular, are orders and results. But you also have, on this page, you have vaccinations, and you can look at FHIR requests that are coming through as well. So it's take a time to take a look at this site if you wish. There's actually a little story you can walk through about Mia and see how this patient's data is being sent across the different points. So, yeah. Let's see. So care quality is another health information exchange that I alluded to earlier. It's essentially from the second largest or first largest vendor, however you look at it, of EHR in the United States, called Epic. And like I mentioned earlier, that in August, now these two networks actually talk. So you're able to see the overlap between the systems, and we're able to have a much broader reach from interoperability. So you should be able to get records from any anywhere in these areas. And it kind of overlaps with the population density in the United States. So various types of clinical data are shared, including orders, results, clinical documents, even PDFs, CCDs, HL7 messages, scanned documents, and even text are sent back and forth. So here are some highlights and benefits of this, what interoperability is today. So you can have advanced prescribing, where when they're actually giving the medication, they can reconcile all the patient's medications no matter where they came from. You can actually reduce costs in that way because there's live pricing to see what's the best cost. A PDMP, which I'm not sure if that's very common here, it's a prescription drug monitoring program. You can see where another patient maybe had retrieved a controlled substance such as opioids. So they don't have duplicate prescriptions for that. You have admission, discharge, and transfer messages that allows you to, as a family doctor, be sent a message that your patient got admitted or got discharged or got transferred, more real time than getting a fax 2 weeks later. And actually providers can send direct messages securely between them to manage patients. And finally, images can be sent seamlessly as well, so you don't need to carry around a physical media like DVDs to show images. So interoperability provides better access to data, enabling more informed care and management. With easier access to health information, hopefully patients will be able to manage their own healthcare better. But providers want to use interoperability and still stay in their workflow. They don't want to come out of the workflow, go to a different system. They want to have it right there when they need it. They want to get the right information, they need the right time to make the best decision. So spending less time searching for information and devoting more time to caring for patients is their goal. It reduces manual data entry, and data sharing provides a more comprehensive picture of the patient, informing providers of patient problems, allergies, medications, and immunizations. I'd just like to show you a couple testimonies from doctors that have been using interoperability. So in the emergency room, this is where sometimes patients aren't quite mentally cognizant of their entire history. The family's not there. You're in a very rush to make sure to make the right decision. You need that key information to make sure you make the right choice on how you're treating the patient. You don't want to lose time. Sometimes it can mean the difference between life and death if you have the right information. So this provider, for example, was about to treat a patient with some imaging, needed a CT with contrast, and because of interoperability was able to find that the last time that they received contrast, they had an anaphylactic reaction, and was potentially able to avoid patient harm and maybe even death if it had been the right situation. So from my own perspective of seeing patients, I can tell you that using faxes is not ideal. Interoperability is a huge improvement, and whatever was done in the past. Having the information beforehand, before the patient actually walks into the clinic, is much better. It allows you to make a care plan before they come in instead of giving them some suggestions on what you could do and trying to read through 30, 40 pages of information of discharge summary. So this provider just talks about that as a family doctor, really appreciates having those outside records before the patient shows up. So now I'd like to change gears slightly and discuss probably what is the biggest test of interoperability that Cerner has had to surmount, and that's connecting the data of the United States' military system. In 2015, Cerner was awarded, among others, a part of a partnership, a $4.3 billion contract to overhaul and manage the electronic health records of the Department of Defense of the United States. In May of 2018, Cerner signed a 10-year contract with the Veterans Health Administration to totally replace its EMR called Vista. Cerner's previous success with interoperability may have contributed to their ability to get these contracts for Coast Guard, Department of Defense, and the Veterans Administration. So this multi-year rollout may be one of the biggest challenges that Cerner has to face in terms of being able to share data not just between the military systems, but also with the civilian care community providers, which can make it difficult because they're outside of the military health system. So this is an overview of the scale of just the Department of Defense and the Veterans Administration. And these facilities are spread throughout the entire United States. So you can see 18.7 million beneficiaries. And it needs to work and work very well. It's in the contract, and that's what we expect nothing less for a system that serves our military. So establishing seamless healthcare interoperability for the U.S. military is a daunting task, but it's something Cerner is honored to work on. The Electronic Military Health System, MHS, has a code named Genesis. So here you can see the different stages the military personnel may go through during their career. Military personnel often spend a large part of their lives being cared for in the military health system. Some of them are even born as babies into a military family, and their records will be in the military system. So, and if they choose a career in the military later in their life, they essentially will be in the Genesis health system their entire lives, so have a longitudinal record of data. So since the military health system cannot be everywhere, sometimes military personnel have to go to a community-based provider. So there's a need to exchange information between the military system and the community system, as you can see in this slide here. And all that interchange relies on the Commonwealth, relies on care quality and the health information exchanges. So now that I've really quickly summarized the past and the present of interoperability in the United States, I just want you to kind of imagine what the future could be like. Let's come up with a couple ideas. How about international interoperability? That's something we talked about earlier a bit in the previous talk and in the questions. So many times myself, I've seen patients that had a lot of their care done overseas. Perhaps they were refugees, and they had records, and they brought some records, but they were kind of spotty. They didn't really have the complete picture. How great would it be if a patient crossed a country boundary and their records are translated to the provider's language, and all of the labs and are all changed to the local representations automatically? That would be a great idea for interoperability in the future. You might also imagine a future where information provided by interoperability is used to make a learning health system, one that learns about the patient programmatically, where individuals are followed across their lifespan, and sometimes if they have a health risk, they are notified that they're at risk of some impending health problem. In the ONCS 2015 Shared Nationwide Interoperability Roadmap, as you can see up here, it's a busy slide, but this is the actual graphics provided by the U.S. government. They stated their goals in 2021 and 2024 were to achieve nationwide interoperability that enables a learning health system on that data. They want to have the person at the center and a system that continuously improve care and provide real-time data access. So the data science teams that I'm a part of at Cerner and at Cerner's clients have been working toward this goal for several years now. I'd like to provide a brief overview of our efforts. The environment where Cerner and its clients spend a lot of their time building tools and models is called the Healthy Data Lab. In terms of data storage, Healthy Intent that you see here on the left is Cerner's enterprise data warehouse. It's where all the data is stored, all the data is dumped there. And they can store about any type of data, as you can see on this slide. The data can then be analyzed by Cerner's Healthy Data Lab. And I don't want to admit it, but I spend a lot of time in the Healthy Data Lab, more than I'd like to. In August of this year, Cerner formed a strategic partnership with Amazon Web Services to provide storage, processing power, and access to some of their AI tools. And Healthy Data Lab can live, it's an agnostic tool. It doesn't have to have Amazon, but that's where it lives currently. So here are some examples where Healthy Data Lab users that were given interoperability data about their systems. They built tools to have a smarter healthcare system. At Cerner, data scientists are building models in Healthy Data Lab to help improve patient care by, for example, predicting what's the chance a patient's going to be readmitted, or what's the chance that they're going to develop a chronic condition. And Cerner clients are also using the Healthy Data Lab. They can have their own environment where they have all their data together in one spot, and they have access to R, Python, SAS, other tools. They've used it, for example, to have a no-show risk. Like, what's the chance that this patient's not going to show up to their appointment? Which is a big deal, because it really disrupts the scheduling and seeing of patients. Others have actually come up with a model that recommends where should a patient go to when they're discharged. Are they really okay to go home? Or should they go to an intermediary location before they actually go home? So using Healthy Data Lab to make healthcare smarter gets us closer to that vision of a smarter healthcare system. But just using clinical data, in my opinion, is inadequate. It's not enough. Medical care is actually estimated to only account for about 20% of the modifiable factors that lead to a person's outcomes. There's a lot more there than just the doctor interaction. The other 80% we call in the US social determinants of healthcare. So it could be their behaviors, it could be their socioeconomic factors. Were they raised in a poorer family? Do they have good connections to other individuals? And environmental factors. How good is the air quality? What's the water quality? The US actually spends a greater percentage of gross domestic product on medical care and less on social programs than many other countries. Despite this high clinical care spending, US outcomes are among the lowest in developed countries. The hope is that addressing these social determinants of healthcare could improve outcomes and reduce costs. I see the integration of social determinants of health plus clinical data as what I've called interoperability 2.0. In interoperability 2.0, we'll have a greater list of factors to understand and build this smarter healthcare system, this learning healthcare system. We can take a more holistic and entero approach to seeing the patient as whole. And you can see some of the alternative elements that we could try to integrate into that system in 2.0. So I'd like to just briefly discuss a project I'm working on. In my day job, attempts to use clinical information plus these social determinants of health. And the goal of it is to understand what is the risk of someone being homeless and living on the street. On a single night in the United States, it's estimated about 500,000 people are unsheltered and sleeping outside. Once a person becomes homeless, their chance of poor healthcare outcomes is very high and increases dramatically based on the statistics. So improving the health of homeless individuals requires attending to those that are chronically homeless, but also those who are at risk of being homeless or are transiently homeless or can come and go in the homelessness status. So using data not just from clinical resources may allow for us to better understand what predicts a person to be homeless, and then we can potentially intervene, try to help them, give them a house, give them access to mental health services to keep them in the best health possible. Here's a map of the rate of homelessness in the United States per state. So many factors may contribute to a region having higher or lower rates of homelessness. You can see it's where there's a higher population density, you're still going to have a higher rate of homelessness. California, East Coast as well. And because there's great variability, they may be doing things differently. So there may be a chance that we can understand that and then help them improve how the chance of being homeless and their health care. So it's human nature. We all want to have a home. We want to be sheltered. However, based on national reports from the World Health Care Organization, There's about 150 million people, or about 2% of the world's population, are homeless. So what causes someone to be homeless is very complicated, and it may be specific to that individual situation. There's a great deal of literature, papers published on homelessness. Unfortunately, there's some overlap on the different attributes they think are causing someone to be at risk of homelessness. This is a schematic or a picture of what obstacles or enablers may influence a person's ability to be sheltered or not, that I came up with in my mind from reading the papers. A lot of them are not health related, but some of them are. So you'll see if they have an illness, they can't get a job, if they have disability, if they have mental health problems, if they have an addiction. But also their race, their native language may prevent them from getting a job. If a criminal history may prevent them from getting a job or getting an apartment or getting a house. In Interoperability 2.0, we can integrate all these data sets to better achieve a holistic view of the patient and hopefully achieve better outcomes. Up to this point, I've been focusing on clinical data and clinical data alone, which I stated earlier really limits our ability to achieve the best health possible. So in this project I've been working on, we've been integrating Medicaid claims. Medicaid is the health system for individuals in the U.S. that have a lower socioeconomic status or a certain disability. They cannot pay for themselves. So if you have Medicaid claims with clinical data, data from homeless shelters, data from criminal records, have they been in a jail, there's a higher risk of someone being homeless if they've been incarcerated, they've been in jail before. Local housing vacancies from census data. The U.S. does a census data every year for locally, but every 10 years there's a new one coming up. There's a lot of information in the census data. Unemployment statistics, education levels. So bringing all this data together on factors that may influence someone's risk of being homeless plus the clinical data. This is how we're going to get the best outcomes for healthcare. If the prediction algorithm is accurate and we have effective interventions, we may be able to improve the quality of life for these individuals while actually reducing the burden on society in terms of financial cost. Since the systems mentioned in the last slide don't have any unique identifier for this person, there are multiple systems and they're fragmented. There's no universal patient identifier or universal person identifier. So this is essentially a diagram of the code I had to write to match up these different systems. It really gave me appreciation for how hard it is. It's not a trivial task to compare James Smith in one hospital to another, because there might be multiple James Smiths. At this point in the project, we've integrated several systems, and although we have a small sample size, these are some of the outcomes we've seen. Nearly all of the homeless individuals that we've looked at have a mental health related medication prescribed to them. Many of them have substance use disorder, SUD, have depression or bipolar disease based on their diagnosis codes. And we're continuing to look at the data and hopefully getting a larger sample size. So, in conclusion, I think the future of interoperability is bright. Interoperability is a key to improving healthcare beyond where it is today. Many of those that were data scrooges holding onto that data before are starting to actually release that data a little more, reap the benefits of information sharing. We have made great progress on the clinical front, but to achieve the best outcomes, as I've been saying over and over, we need to get a better picture of the patients. I mentioned the social determinants of health, but there's also other sources of data, such as biological or omics data. You have genomes, transcriptomes, proteomes, microbiomes, other information that tells more information about the patient. And finally, as 5G becomes more prominent as a standard, and we're going to have more information of Internet of Things technologies, where we're going to have sensors on the body that will tell us more and more about. So integrating all this data, it's almost like Interoperability 3.0. There's so much more we can do. And data science, together with health information technology, are probably going to be more and more tightly integrated in the future as we build these learning systems. And with that, I'll take any questions. Inglés o español, como quieren. Thank you.